Yeah, I'm Matt Corey. I'm moderating this next session. I'd like to invite the speakers to come up. I always learn so much coming to these innovation summits. Synthetic data in my mind was something that would get your paper retracted in the old days, so I'm glad to know that it's okay now. We're going to switch to something completely different now. Now that we're 12 or 13 talks in, we're going to talk about what patients care about. Patients are people. I guess they're also humans, but let's get a little more touchy-feely. And I think there's a lot of ways this large-scale data, where the rubber hits the road, it gets implemented and it gets actioned in clinic. And as some of my speakers here are going to talk about, increasingly digital health is letting us maybe take action outside clinic in the community. I just went from the left side of the football to the right side of the football this last year, so to just get this out of the way at the lunch break, I'm a Buckeye now. I was a Wolverine last time I came to this thing. It's great. Go Buckeyes. These are my disclosures. Some of what I'm going to talk about is my own research. I'm going to move quickly. I was asked to show some of what I'm going to show you today to a group at FDA last week. So they care a lot about this stuff, and they're looking for people that know how to help bring patients in. I start my clinician talks with this: why are we here? Why is this patient here to see us in clinic? They have not come in to see me because they want to have their data ingested into a big model. They're usually there. They're not there because clinic is fun. They usually have some kind of goal that they want me to share with them and accomplishing. It might be improving their symptoms, their quality of life, how long they're going to live. They want to understand their diagnosis maybe. And maybe they're there to avoid harms. I walk into clinic a lot of the time, and the patient's biggest concern is that I'm going to come in that door and tell them they need surgery, and all they want to do is avoid that. And so it's a very different interaction. What does it mean to be patient-centered? We need to focus on the individual as a person with social context. We need to understand what they want, what their wishes are. And I would argue that with a lot of these data, EMR things, what the patient wants is actually absent from these data sets we've been talking about all day. A lot of different, this is a PAD-oriented panel, a lot of different options out there. This is the latest AHA guideline, and I think my colleagues here are going to be talking about supervised exercise, and that's right at the top for claudication, right? So for patients that don't have a wound on their foot or rest pain, but they got symptoms, exercise, we're calling it structured exercise, is part of guideline-directed management. Everybody's supposed to get it, but it doesn't always work. What are the pitfalls in treatment selection for PAD? Well, our clinicians have time constraints, communication gaps. We might be incentivized to do stuff to people. Our scope of practice might affect what we offer. There's productivity expectations, revenue expectations, and costs. The current state, our guidelines recommend that we make shared decisions, but the reality right now is that the doctor usually recommends and may, offer up a treatment suggestion without necessarily discussing alternatives, and that puts us in a situation where we can have strategies that don't match what the patient values or wants. That can lead to over and under treatment for claudication in particular, dissatisfied patients, and unnecessary risks. And there's been a lot of lay press coverage about how often we get this wrong for claudication. I admire the people putting this out there because it's an uncomfortable discussion, but the fact of the matter is sometimes we put patients into a situation where we can't take back what happened, and we really are asking what if and why did this happen, and what were we trying to do in the first place here. This is a great editorial about valuing what patients want, and it really focuses, it's a little dated now, but it's still quite relevant, on how hard it can be to actually get to that in a clinic visit. I have a 15-minute slot for my return patients in my clinic where I'm supposed to walk in, do the exam, interview them, update their medication lists, review all their intake stuff, write a note, make a plan, put the orders in. So that's a lot, and it moves quickly for the doctor. It's not actually up to the doctor anymore how long they get with their patient in a lot of places. So a lot of constraints around this that make it hard. Patients also can't always tell us what they want, or they might not have thought it through before they're in the room with us. There's some people that think that our patients, have health risk behaviors that kind of is why they got their vascular disease, and should we be listening to what they want because they wouldn't have their PAD if they had been smoking all their life. So there can be a lot of judgment on the physician side of this. The other screwy thing with PADs, it's chronic. So we don't make a decision, we're done. The merry-go-round keeps going round and round. We revisit these decisions over and over and over again. And for patients with claudication, there's 5 or 6 different things you can do to one or both legs all at the same time or one at a time in order. We surveyed patients in some of my previous research, and most of them say they want to hear all the options and choose a treatment together with the doctor, but only a little more than half report hearing about options, more than one choice. For the PAD patients in this study, 35% of the patients said none of their treatments have been successful at all. 35% said a successful treatment was identified, wasn't the first one I tried. So a lot of room for improvement. This is a photo from the inpatient unit where I work at Ohio State. And this is how we talk to our patients a lot about treatment outcomes and goals. How far can you walk? In the medical journals and the literature, you'll see stuff like this as outcomes for walking performance metrics. Treadmill testing, how far can they go? 6-minute walk test has taken off a lot and is hard to not get force-fed in an NIH proposal. How long? I can tell you, none of my patients come to my clinic and say, I really wish I had 20 more meters on my 6-minute walk test, and that's why I'm here today. None of them come to me and say, I wish my ABI was a little bit higher. That's not why they're there. So there's some gaps between how we think about why patients, what they're trying to get, and how we're going to get there. I've done some focus group research where patients really report a really heterogeneous experience in clinic. Am I being too evangelical? Sometimes they feel like they're partnering with us, and other times they feel like we don't care what they want, and we're going to talk over them and ignore what they want. Sometimes they don't trust their doctor. They don't say you shouldn't believe what your doctor's saying. You need to go get multiple opinions before you believe your doctor. This is hard to read. These are some of my patients in these studies. Some of them complain about the timeline of going over and over and around the bend 50 times before somebody would test them for their PAD. So a lot of relevance with some of the screening discussions before. A lot of concerns over fragmented care, having to see their doctor in the emergency room because their vascular specialists have abandoned them. Out of those focus groups, we were interested in what do patients want. We pulled these treatment factors that we thought were relevant to specific, what are we going to do for your PAD today? And we did some discrete choice surveys where we walked the patient through an experiment where they compared theoretical treatments and kind of had to choose based on these treatment attributes, which are, what is the intervention? What is your symptomatic response going to look like? How often is it technically successful? What's the durability of it, and what's the risk? And when you pull out individual patient preference phenotypes out of this, and this is in patients with similar disease severity, boy, if you're willing to look at this data in a situation at equipoise, you'd really choose something different if you bothered collecting it. That patient on the left there really prioritizes durability and is risk tolerant. The next patient over is risk averse. You could really sort of personalize what you're going to do based on what they want. This work came out of a previous innovation summit, thank you Vascular Cures, where we actually surveyed patients about why are you here? What are you trying to get out of your treatment? We asked our patients, what's the minimum amount of walking duration improvement? These are all claudicants. You'd find meaningful based on, would it make it worth having a treatment? And I was astounded by this. We split them into sort of short and long distances, but most patients said 10 minutes or more, and a lot of them said 30 minutes or 60 minutes longer is how they would think they're better. That's a big gap from what we often deliver through clinical care. Same thing when we conceptualize it in terms of distance. Look at this, 1/2 mile or more for a lot of the patients was what they said would be a meaningful improvement in PAD symptoms. I don't feel confident we can always promise this to most of our patients. Who in here can tell me what in the medical literature we say is a minimum important difference in improvement in 6-minute walk? Anybody want to have a guess at it? published literature is 8 to 20 meters better. And that falls right here. So patients don't think that's meaningful. And this is a big part of the problem, is we take what we think is a meaningful difference based on a group of patients that are put together, and we look at mean data. And when you get down to the individual patient, it can be really meaningless. And what we say in a medical journal is better isn't really better to that person. In this survey study, too, we asked the patients, if you don't want to walk longer or in terms of time or distance, what is your goal? And these are the kind of self-reported activity goals that patients brought out. This is the real why they want to come to clinic, what they're trying to do in their life that they can't do. That bottom one on the right, dance, clean a house, that was a 70-year-old woman who had had claudication with bad iliac disease for 25 years, and her OBGYN physician treating her for that just basically told her to quit complaining and walk more. We did an iliac stent on that woman that took about 20 minutes, and she was in tears in our office about how much better she was. That was an example. So if I had to pick my top 3 pressing unmet questions, and these are really based around exercise therapy, because that's what I think my panelists are going to talk about, and these are just my choices. I was asked to come up. Number 1 would be, how do we integrate structured exercise data into clinical management? PAD never occurs in a vacuum. These patients have multiple chronic conditions usually, and sometimes it can be hard to decide when the PAD should be the priority or the back burner. And hearing some of the PAD-focused AI, patient screening stuff here is great, but what about that patient who's got asymptomatic PAD and they're here for their colon cancer today? Is that really, do we need to be front-loading their visit with an attack on their PAD? How do we set realistic goals that include the clinical data, but also what the patient's getting out of their exercise? When can we identify intentional exercise versus something else with activity data, like non-exercise walking? Can we tell why the patient stopped walking when they stop? And, kind of relevant to that computer vision, where should the digital health intervention and the data reside? Should it be in the EMR or somewhere else? Question 2 I would pose to the panel, how should we respond when structured exercise seems to be failing? Is it a lack of the patient's adherence? Is it a lack of persistence? Or can they just not, is it actually technically failing because it's a bad choice for that patient? We need to think about another treatment. Who is it that decides it isn't working? Does the patient tell us it's failing, or do we reach out to the patient? Or maybe can we use AI to monitor their activity in real time and get to that quicker so that they're not coming back for a clinic visit in 3 months? How much communication is too much? There can be a fatigue, just like the alert fatigue we talked about for clinicians in the EMR. If we're bombarding our patient with 27 texts a week about why didn't you walk today, it may have an unintended consequence. And this is the distinction between those terms. Adherence is the extent to which the patient's going to continue on the agreed upon mode of treatment with close supervision. So adherence fails when the patient decides they don't want to do it anymore. Persistence is obstinate continuation of the behavior or existence despite treatment. So is the patient failing exercise because they've decided they don't want to do it anymore, or because they can't stick with it, or because they're not a good candidate for it? And my final question, I would say, is how do we right-size treatment intensity for claudication? We want to avoid over-treatment where the risk is greater than the potential benefit, but we also want to avoid under-treatment. And sometimes in claudication, when exercise fails, you have the option of actually stopping. You don't have to go do the next thing and escalate if it's not worth it to the patient. If I was going to map this out, this is how ideal treatment would look, is on the line. Conservative treatment for patients with mild symptoms and good quality of life. Aggressive treatment, point C there, for patients with severe symptoms and low quality of life. And B and D are what over and under treatment look like. So there's my 3 questions. I look forward to all the discussion. Here's my new email. Come see me. I look forward to inviting some of you to come present in Columbus in the near future.
I guess while my slides are coming up, I'm Alex Vanneroff. I'm an interventional cardiologist from Pennsylvania. Also a clinical trialist, behavioral economist, sometimes implementation scientist. And, oh boy, that went too far. So I'm going to be talking today about increasing adherence to physical activity in patients with atherosclerotic vascular disease, including patients with PAD, using some insights from behavioral economics and work that our group has done. So here's my disclosures. The work that I'm talking about was funded, mostly today, was funded by the NIH, the National Center for Advancing Translational Sciences, and NCATS. So when I think about PAD as a cardiologist, I think about it on a continuum, and there are a lot of opportunities to improve PAD care, from primordial prevention in patients that don't have atherosclerotic vascular disease to primary prevention, secondary prevention, and amputation prevention finally, when they get to more severe disease. And when we think about people with PAD, we know that there are missed opportunities for care sort of along the continuum. And this is sort of a synthesis of data from a number of studies, particularly in patients with diagnosed PAD. And what you see is that less than 40%, again, antiplatelet therapy, less than 40% get statins, less than 40% smoking cessation counseling, and less than 2% get supervised exercise therapy. And I actually think, as a cardiologist, I think broadly about the population of patients that can benefit from these things. It's not just the patients with PAD that we diagnose, either by screening, ABIs, or by some other way. There are patients, that have asymptomatic disease. There are patients that are developing disease that's not obstructive, and there are patients that are at risk for ASCVD. And all of these patients benefit from these therapies. And, I like to think broadly about that. So to close these gaps and to affect the most people that we can, instead of trying to find new things to do, it's good sometimes to do the things we know we're supposed to do. And a lot of these things relate to getting people the treatments that they should be getting no matter what. And, we talk about it like that's easy, but it's actually quite hard because that involves changing behavior. So how do we think about changing behavior in my group? So I think about it like a behavioral economist. Behavioral economics is a field of study that seeks to understand why people make the decisions that they make, and then use those things that you learn about how people make decisions to influence the decisions that they're making. And sort of the deans of behavioral economics are Daniel Kahneman, who won the Nobel Prize in Economics in 2002, and then Richard Taylor, who won the Nobel Prize in Economics in 2017. So a traditional economist thinks that people make decisions like this. They have a bunch of data, they take it all in like some sort of machine learning model, and they spit out the correct decision. And that's not how people actually make decisions. What we know is that people are limited by time constraints, cognitive limitations, and imperfect information. And all those things conspire to make it so that we can't actually make an optimal decision most of the time. And we do what's called satisficing, or we sort of make a decision that's good enough, and we make a suboptimal decision. And so how do we do this? We do this with what are called heuristics, or rules of thumb. And some important ones are immediacy bias, status quo bias, and the endowment effect, which I'm going to talk about in the next few slides. And what ultimately happens is there's a disconnect between the planner, who wants to exercise or save for retirement or get their patients on the right medicines, and the doer, when you actually have to do the work, where you just want to, when you come to do it, you just want to watch TV or spend money or leave clinic on time. And what this comes out to is this concept of bounded rationality, where our decisions are not fully rational. And so one key one is immediacy bias. There was a series of experiments done, I think about 20 years ago at this point, where they showed that $15 now people value about the same as $30 in 3 months, or $60 in 1 year, or $100 in 3 years. And that's fairly abstract, but the way I think about this is, our patients with heart failure who are making the decision between, eating a salty meal like McDonald's and not being hospitalized. And what wins out is eating the salty meal because it's more immediate. So the pleasure now outweighs the pain later. Next is status quo bias. This is the idea that people resist change. So this is sort of the classic sort of non-experimental study here. This is looking at the people that indicate that they're willing to be organ donors in various countries. In the yellow countries, they ask the way that we ask in the United States, which is to say, when you get your driver's license, do you want to be an organ donor? Check yes if you do. And in those countries, very people are organ donors. In the blue countries, they frame the question the opposite way. They say, if you don't want to be an organ donor, check no. And so most people in those countries are organ donors. So this just goes to show you that, people, take the easy way out. They do what's easy. If there's a box to check, they won't check it. And that's what we call status quo bias. Last is the endowment effect, which I think is sort of one of these somewhat counterintuitive things in behavioral economics that's been shown in a bunch of experiments. And this is the idea that ownership increases utility, or people like things that they have more than they like things that they don't have. And the classic experiment here was Kahneman and Taylor gave a bunch of college students mugs. So they gave every other student in a classroom a mug. Then they separated them, and they asked the students who had the mugs, how much would you sell this mug for? And they said $4.50. Then they asked the students who didn't get the mugs, how much would you buy a mug for? And they said $2.25. So just having the mug that you just got makes it worth twice as much to you as if you don't have the mug. And it's not just humans or college students, it's also chimps. So researchers gave chimps peanut butter, and then offered them a popsicle. And chimps, it turns out, like peanut butter more than popsicles. So 89% of the chimps kept their peanut butter when they offered them a popsicle. Then they gave chimps popsicles, and they offered them peanut butter. And we know chimps like peanut butter more than popsicles, but it turns out that 60% of their chimps kept the popsicle rather than taking a peanut butter they didn't have. And we can use this to design interventions. So that what you see here on the right is an experiment done by the group at Penn, where they gave Penn employees wearable fitness trackers, and they had them set goals to increase their steps. And then they had either no incentive, a gain-framed incentive, which is if you do this, we'll give you something, money as it turns out, or a loss-framed incentive, which is if you don't do this, we'll take your money away. So in the control group, about 30% of people met their goals. In the gain-framed incentive, 35%, and in the loss-framed incentive, same incentive, just framed differently, 46% met their goals. So we applied behavioral economics to medicine in that way by designing interventions that make known biases in decision-making work in your favor instead of against you. You're changing the decision environment. And so I want to talk a little about supervised exercise therapy and how maybe we can increase the number of people that are exercising if not engaging in supervised exercise therapy. So we know there are a lot of barriers to supervised exercise therapy: cost, travel, and distance, which is compounded by lack of availability about half of centers, and inability to commit to sessions 3 times a week, among other barriers here. And so how do you surmount these barriers? Well, maybe you could make it free, at home, on your own time, but how do you do that? I mean, people that, exercise physiologists that do supervised exercise therapy are good at their jobs. You can't just get rid of them and hope people are going to do it anyway. And so what we've done is we've tried to apply concepts of behavioral economics to make it easier for people or motivate people to exercise more. And the idea here is that physical activity sort of begets physical activity in sort of this virtuous cycle, ideally, where you get someone started, and then their symptoms get better, and then they can walk more, and then they walk more, and sort of get better and better. So what if we could apply like a little nudge here to get people started using concepts from behavioral economics? So that's what we did in the GamePad trial, which was a randomized trial of behavioral design gamification and automated coaching versus attention control to increase physical activity in patients with PAD. So what we did is we identified patients with PAD, we gave them a Fitbit, we got a 2-week baseline step count, and then we had them set a goal to increase their steps. They then got randomized to either intervention or to control. It's a 16-week program followed by 8-week follow-up. So the patient population was adults with PAD. They had to have a smartphone or tablet that connected to the internet, and then we excluded patients with chronic limb-threatening ischemia, prior amputation, or plantar vascularization. And this is how we did it. So we identified patients in the EHR, and then we sent them emails or text messages with a link to the Way to Health platform, which is a platform we have at Penn that automates the delivery of behavioral interventions. So it enables patients to enroll online, fill out baseline questionnaires, and then you can connect wearable fitness trackers, and then you can develop sort of a rules engine within there so that if they meet their step goal, for example, they get one message. If they don't meet their step goal, they get another message, and you can also automate the delivery of financial incentives, though we didn't do that in this study. So once the patients enrolled in our Way to Health platform, we mailed them a Fitbit, and then they wore it for 2 weeks to get their baseline step count, and they set a goal to increase by 33 to 50% above their own baseline. And we found that having people set their own goal actually helps them be more likely to achieve their goal. They were then randomized. So in the attention control arm, participants got a daily text message noting whether they met their goal the day before. That was it. And the gamification intervention had several parts. The first is people signed a pre-commitment pledge where they pledged to meet their step goal. Second was we had a ramp up to their goal step count over 4 weeks. So the first week they increased by 25%, all the way up to 100% of what their goal was. Then we entered them into a game with loss frame points and progression through levels based on accumulated points. So the way this worked is we gave them 70 points, and they lost 10 points on days they didn't meet their step goal. And if they had 40 points or more at the end of the week, they moved up a level. If they had less than 40 points, they moved down a level. And the levels were meaningless. It was just 5 levels, and they had colors, and so. And then they identified a support partner who got a weekly email update with how their participant was doing in the game. And then we also sent them text messages twice a week about the benefits of walking in people with PAD. And so we used several important behavioral economic concepts in this intervention. So first was status quo bias. This went on in the background. People just got text messages. They strived to meet their goals. They didn't have to go to a website or to go to an app or anything like that. They were in it. Once they were in, they were in. Next was immediacy. The points were taken away every day instead of forcing people to think about how they might benefit later on in the future. And then the last was loss aversion, which is part of the idea of prospect therapy, which is we took the points away instead of giving the points. So this is our consort diagram. We emailed over 5,000 people to offer them enrollment. And I think that one thing to highlight here is that 94% of people didn't do anything. They got the email and they ignored it. And I think that that's important to think about. How do you engage people in clinical care? Ultimately, 282 people completed the screening survey, provided informed consent. We sent 184 Fitbits, and then we randomized 103 patients. You see that the reason we excluded most of the patients was actually, the largest number of patients we excluded was that they were taking too many steps at baseline, and we thought that these weren't patients that really were limited in their ability to walk. 94% of people completed the whole study, and we had physical activity data for 90% of participant days over a 24-week study period. So we got a lot of data. People participated. It was good. Here are baseline characteristics. These are patients with PAD that are seen in routine clinical practice. Mean age was 70, 52% were male, 16% were black. Mean BMI was 30, 11% smoked, 36% had diabetes, and 72% reported that they had some lower extremity symptoms. And then the mean daily steps was about 4,500. So these are people that are not walking very much. And these are our primary results. The y-axis is mean daily step count. The x-axis shows weeks. What you see is that in both groups there's an increase once they set their goal, but that the intervention arm increased by a lot more. So by the end of the main intervention period, the control arm would increase their daily step count by 783 steps more than baseline, gamification by 1,499 steps more than baseline, or 920 more than the control. And that was, the p-value was 0.06, unfortunately. In the follow-up period, by the end of the follow-up period, the control arm had a decrease in their steps from sort of their peak. They were up to about 617 steps more than their baseline, and the gamification continued to increase, consistent with that theory of sort of the upward spiral, to 1,811 steps. And the p-value there was significant for change from baseline versus control. And then I think these are some intriguing findings too. We looked at quality of life using the walking impairment questionnaire, and these results are not significant for any of these because the sample size was small. We weren't powered for that, but increases by about 10 points in the WIC and WIC distance and WIC speed, and then an increase in the SF-36 health change score too. So hypothesis generating, p-value is not significant, but directionally consistent with what we saw with daily step count and what you might expect if people increase their step counts by about that much. And we've done this in more patients, different patients. This is the Be Active clinical trial. It was a larger trial, and I present this only to show that, this is 100 patients in the PAD population. This is the Be Active was 1,000 patients with follow-up to 18 months, and gamification increased physical activity by actually about as much as can feel financial incentives, though not as much as the combination. So a useful strategy to increase physical activity in patients with atherosclerotic vascular disease, I think. So in conclusion, concepts from behavioral economics can be used to design an intervention that increases physical activity in patients with PAD. It's inexpensive. This program, costs about the cost of a Fitbit plus maybe $50, mostly in text messaging fees. Inexpensive, easy to deploy, doesn't require specialized personnel, facilitating scalability. But engagement with digital and non-traditional health interventions remains low. About 6% of people that we contacted were interested in participating. So where does this fit? I don't think that home-based, unsupervised, unstructured walking should replace supervised exercise therapy, but with more evidence, it could be an option for patients that refuse or aren't candidates for more intensive options. But who are these patients, and where are more structured programs not available? So 3 big unanswered questions. So does unstructured, unsupervised, home-based physical activity improve symptoms, walking distance, and/or quality of life in patients with PAD? I am submitting an R01 to try and answer that question, so if any of you guys have some ins at NHLBI, just put in the good word for me. But what are patient perceptions of this sort of program? Is the relatively low uptake in our trial an artifact of sort of the need for informed consent, the fact that it's really hard to reach people by email and text messages because people are bombarded by political campaigns and everybody else trying to get their time on their phones? Or does it reflect a lack of willingness to engage in an intervention like this? I think it's the former, because when we call people and ask them if they want to participate, they're excited to do it. But when we send them a text message, they're a little bit less excited. And then what's the best way to engage patients with PAD in digital models of care? Thank you.
Next up, we have Dr. Sharma and Crystal Short from the Kaiser system. And then when they get done, we have Tim Campbell, who's here and is going to give us perspectives from a patient and caregiver lens. We're going to get done. I've been informed we're going to get done by 12:40.
All right, we'll try to zip through this. So I'm Gaurav Sharma, as we said, one of the vascular surgeons at Kaiser Permanente, and this is Crystal Short, one of our clinical practice consultants. And so we heard an excellent talk by Dr. Fanaroff looking at how can we shape patient behavior and get them engaged with digital health solutions for behavior change. And we're going to kind of continue in the same vein, but we're going to shift gears a little bit. And so instead of focusing on the individual patient level and the nudges and things to get them to act, we're going to talk about building out systems of support and the infrastructure to get patients engaged with the digital health technology. And so I'm going to start by giving some brief background that builds on what we've already heard and really frames what's the issue that has occurred to date with this. And then we'll talk about a new program that we've developed and recently implemented to try to tackle some of those issues. And then finally, we'll talk about some of the takeaways, challenges, and the next steps. So in terms of background, now we've heard at this point in the summit about peripheral arterial disease, atherosclerotic narrowing of the lower extremity arteries, and this has really become a global scourge. Within our country, it affects all patient populations, but particularly the elderly and our Black and brown patients. And it exacts a huge toll on these patients and their families, and also is a heavy burden on our healthcare system, with these patients generating expenditures that are threefold higher than comparable patients who don't have PAD. And so the most common manifestation, as we've heard, is intermittent claudication, which is a painful and disabling condition. It impairs their walking, their ability to function in activities of daily living, and impacts their function and quality of life. And nuances notwithstanding that we heard about at the top of the session, in general, the way to go with intermittent claudication initially is not invasive procedures, but is non-invasive modalities. And specifically, supervised exercise therapy has the highest strength of recommendation in the clinical practice guidelines. And what supervised exercise therapy is, just to go in a little bit more detail, is that the way that it's conceptualized, generally speaking, with some modifications here and there, is that it's a 12-week program, and patients do 30 to 60 minutes sessions of resting and walking, and that's multiple times throughout the week. And then that's delivered by qualified auxiliary personnel under the supervision of a healthcare provider. And it sounds very simple, but it has this incredible impact on patients when you compare it to the other modalities for treatment. And so it's shown to impact longevity, it decreases invasive interventions and surgeries, it improves function and quality of life, and it's a cost-effective modality. And so as a result of that data, in 2017, so now 7 years ago, the Centers for Medicare and Medicaid Services, CMS, made a national coverage determination that they're going to reimburse supervised exercise therapy. So in spite of all those benefits and then the reimbursement decision, uptake has been very poor since that time. And so in 2020, investigators reported on why would that be the case and when there are so many potential advantages. And as you'll see here from this list, many of them are logistical reasons. Then along came the pandemic, and then that just exacerbated those logistical issues. So last year at the Innovation Summit, we heard from Dr. Alami, who talked about a novel mobile application that the CellEd company had developed to address these issues. It incorporated health coaching based on some prior data as well. And that, during their feasibility studies, was shown to be very successful. It had high completion rates, it improved the functional outcomes, and then also helped patients avoid invasive interventions. But when you look at the most recent data published earlier this year, we see that still the referral rates are poor, the enrollment rates are poor, that it really still hasn't been uptake. And that's really the question that we wanted to address with this project was, how do we drive patient engagement and this digital health solution that has been shown to benefit their disease process? And what are the gaps, and can we shore up those gaps? And so in developing that, we hypothesized there might be characteristics of the patient population, be it age or other things, that really meant that we had to shepherd these patients a little bit more to the digital health solution, get them engaged, and then reap the benefits thereof. And so we had to develop the program, we had a collaborative, multidisciplinary process. We've gone through many iterations before we launched, and kind of the key things that we learned from that process was, one, we really had to understand the target patient population, their needs and their preferences. Another thing that we learned was we really have to engage too with the referring vascular specialist to get the patients to the program in the first place and limit some of the barriers to entry there. And then as we were making iterations and changes, we always used as our lodestar keeping kind of a patient-centered framework and really emphasizing sustained behavior change and trying to do what we could to achieve that. And so initially, the PAD care in our region is decentralized. It's fragmented across the different centers. And we thought for this program that really it would make more sense to centralize and have a small group of champions that were going to push this and try to get patients engaged with the digital health technology. And then this is the workflow that we came up with, as you see here on screen, right? And so I'm not going to go through all the granular details of it, but some of the kind of key features are, number one, at that starting point, we worked with the referring providers to build on their existing workflows so that we were minimizing some of the barriers to entry to getting patients to the program in the first place. And then, as we said, we centralized because that allowed us to have a small group that was the point of contact for these patients, both when they're initially engaging and then throughout the process when there's a little bit less interaction needed. There was also one thing that became key through the process was regular communication with the technology providers, so CellEd, the app platform, and the clinical care providers. And by breaking down the silos between the two, that really helped create integrated solutions when we ran into trouble along the way. We had clearly defined safety protocols, and then we had a less intensive sustainability phase after that initial 12 weeks to see if we could, again, sustain the behavior change over time. And then finally, we thought that assessment of it would be important, so we had predefined goals and metrics of success and an assessment plan. And one of the focuses of this subsection is really on driving that patient engagement. So I want to turn it over now to Crystal Short, who is one of the key team members in designing that personalized patient touch point that has been really a key to success and engagement.
Thank you. All right. So as Gaurav has discussed, the parameters and the requirements of this program are really complex. And so as an operational leader, what I really did was I took these requirements and built a system where this could be standardized and delivered to our patients. I did for the technology component added an additional complexity. And so how did I do this? So I needed to account for this. So first what I did was I built a solid plan. So I asked myself who, what, when, how, and how long. So I started with this solid plan. In our operational meetings, it was determined, we determined the basics of how long, and we asked ourselves questions such as, who would be doing the work? What types of patients would likely be participating? What would this program look like? When would we start? We asked ourselves these questions. How long would the program run for? When we had these items identified, we then created an extensive playbook. So we standardized tools, we had playbooks, scripts, protocols, we had escalation pathways where we were going to have medical assistants specifically do most of this program and actually having the CellEd app get to the patients. And so the medical assistants really became key in getting the CellEd application to the patients. So, and then we focused on the people. So we wanted to ensure that we involved our leaders, our program manager, our physicians, RMAs, and also our patients. So we wanted to ensure that we were thinking about all of those people as we developed this program. So there are a few learnings that I want to share with you that we really had. These are the key learnings that we identified early on in this process. So the first is create a process. Include all parts of the process in your planning. Include those who will be doing the work. Create standardized processes, especially for the MAs. Make sure that it's really clear on what your medical assistants will be doing. Make sure that they know how they will be contacting the patient. Make sure that they know that they have those scripts, and make sure that they know what wording they will use. What I did specifically was have training sessions with our medical assistants so that they would know those nuanced words with technology, such as knowing how our process in the beginning, because one of the things that I thought was, okay, this is a technology, an app, it's an application-based program, so let's make this a technology-based solution, right? And so a lot of the sign-up process was technology-based. And so we sent an email to the patient, they would have a QR code. Well, a lot of the patients didn't even know how to scan the QR code from their email. And so one of the things I had to teach was, okay, how do we walk the patient through being able to scan that QR code from their email or from their smartphone? And so learning that and training the medical assistants, because my medical assistants didn't know how to do that either. And so really learning how to train them. So what I learned early on was that this was not a scan and go process, not at all. And so even though this was a technology-based solution, the patients and that demographic, they wanted us to call them and walk them through this. And some of our patients actually even needed us to bring them into the office and walk them through that is what they really wanted. And once we learned this, and good news is we identified this early, because our third learning was that we checked in often. So as Gaurav said, we checked in with Cell Ed, but we also checked in with our medical assistants. We actually checked in once a week with them to see how the sign-up process was going. How many patients were we getting responding to those emails? And we learned very early on that they weren't responding. They weren't signing up for the application. They weren't scheduling those appointments as we had thought, oh, this is so slick, they can just schedule their appointment online. They weren't doing any of that. And so once we learned that very quickly, we were able to adjust our processes. So the fourth learning is be okay with change. Be okay with change early and make those changes early on if you need to. This is an iterative process and things will change, but be okay with that and your program will be successful.
And so this program is still in its infancy, and so we launched in April of this year at the 5-month time point. You can see the numbers here. We had 66 patients meeting inclusion criteria that were referred. 6 during the onboarding process ended up declining, so 60 enrolled, and we've only had 1 withdrawal so far. We've had good patient engagement as well, 0 safety events. And at that 5-month point, 4 patients had completed. Actually, several have completed since now, and they're entering that sustainability phase where they're going to be working locally with health coaches virtually to try to continue to sustain the benefit there. And then in terms of the endpoints that we're collecting, that it's a little too early, obviously, with these numbers to do the analysis plan, but these are the endpoints that are collected through the mobile-based application and then through minimal extra work by the team, their process measures, safety endpoints, and then outcomes as well, which is a combination of the conventional ones, the freedom from intervention and survival, but also the functional and then patient-reported outcome measures as well. And then in addition to the quantitative data, one of the benefits of the human contact through the coaches through the app, and then also in our sustainability phase, is some of this qualitative data that, as was emphasized before, is really critical, is understanding what their values are and what we get out of it. This also will give us clues about mechanistic issues with what patients have the hardest time adhering versus not with the program. So moving forward, these are sort of the unanswered questions for kind of the immediate scale for the app and then broadening our view. So one is refining the patient selection for this project. As we saw, there's probably a patient population or a subset that is plug and play. That 6% that we saw from in the previous talk, we'll just pick it up and start going with the app. So we don't need to necessarily throw the resources at the patient population. How do we identify that so that we're using the resources wisely? And then with all behavior change, fatigue from the referring providers and the patient participants is always a challenge. And so how do we sustain the referrals and continued participation in the program? And then what are the long-term impacts? Is this comparable to in-office, in-person exercise therapy programs or not? And what happens longer term once they're out of the program as well? And then widening the lens a little bit. This is one program in one healthcare setting with one patient mix. How can this be applied to other healthcare settings and other patient populations? And what are the necessary components? What needs to be changed in the approach there? And then finally broadening the scope even more, this is PAD, but there's a growing body of research showing the value of supervised exercise therapy for a number of other conditions. So prehabilitation for open aortic aneurysm repair or cancer surgery. And so can this be applied to those settings, and what are the unique challenges in each case? So in conclusion, there are situations where the technology seems like it's not always enough on its own. It needs to be supported a little bit to get patients to engage. And so what we thought helped that process was really understanding the target patient population, developing systems of support and care around the digital technology and that collaboration between the technology purveyors and the clinicians, and hopefully with adopting a patient-centered approach and continually assessing performance and implementing those iterative refinements that Crystal talked about, we can really impact patients' behavior using these digital health solutions. Thank you.
Kim, I'd love for you to introduce yourself to the audience and why you're here. And then after you do that, I'd be real interested, you got the thought leaders in the field in front of you. What have you heard today that resonates with you, and what is your big pressing question that is missing from what you've seen today?
Okay, I'm Kimberly Campbell. I'm a patient advocate for PAD. I got involved with Vascular Cures through my mother, Gertrude Campbell, who was a double amputee. When she became a double amputee, she was chronic, so there was like no interventions. I currently am a registered nurse working in Atlanta, Georgia.
I'm so sorry to interrupt you. I can tell the people in the back can't hear you if you want to.
You're going to have her come up here?
Or just flip forward. I think maybe you can flip forward, you'd be okay.
I'm sorry.
No, that's us.
I'm currently a registered nurse working in Atlanta, Georgia, but I'm originally from Greenville, Mississippi, which is a very rural area in Mississippi with not a lot of doctors and a very small hospital. And we were 2 hours away from a metropolitan area. So basically I was invited here to speak from a patient advocate caregiver perspective. And I've listened to everyone talk throughout the day. And my big question is, how do you get the patients to trust you in signing up for the app? Because a lot of patients where I'm from have a very close relationship with their primary care physicians. And so they don't want to talk to anybody else. And in those areas, some of them don't have Wi-Fi and internet. And me personally, I think it's great. Apps are great. I use my Apple Watch daily to track activity, but working with certain patient populations, I know they are not open to it. So how do you ensure their trust? How do you keep that personal connection with the patients? And do their primary care physicians do any follow-up to see how they like the apps for the supervised exercise and whatever? And I also listened to, there's only like a 16% of African Americans that signed up for the app. So how do you engage that population more when we know that PAD affects the population more than other ethnicities? So those are some questions that I had. Also, level of income and education is a question because I have a college degree. I understand a lot of the medical lingo, but when you start going through lower levels of education for some patients, how do you make it where they understand and will want to participate with this? That's my questions.
Couple questions. Got time for a couple questions from the audience, or I might ask our other presenters, you know, with the questions Kim just asked. So, what were your refusal rates for your trial, and how? Any ideas? Anything you learned from that on how we can do better at recruiting underrepresented populations into these studies?
Yeah, so I mean, our refusal rates were not high, but I think that a lot of people sort of, didn't engage at all. So they didn't accept, they didn't refuse. And I think that it's a really good question, and I think it's a really important question. How do you get people to engage, especially people that don't traditionally engage in this sort of research? We did another. I showed you the data from the Be Active trial, which was our trial of patients with or at risk for atherosclerotic vascular disease, and we looked at sort of enrollment patterns by race and what proportion of people clicked the link and signed up. And it turns out that if you just send people an unsolicited email invitation to sign up for a clinical trial, about 2% of white people will click on the link, and about 1% of black people will click on the link. And also, women are more likely to click on the link than men. And I think that all of these are important questions and gets to the issue of fairness and justice and access to clinical research and clinical trials. I don't know if I have a solution to it, except to say that, one thing we did in the Be Active trial to make our trial more representative is that when we saw that pattern, we stopped inviting white people to participate in the trial, and preferentially recruited non-white people. And in Philadelphia, non-white people is almost exclusively black people. So that's one solution. But I think that, you asked about trust too, and I think that sort of gets to, where there are studies showing that people are more likely to trust clinical research and more likely to accept medical interventions if it was tested, if the clinical trials involve people like them. And so so that's not the only solution to trust, but certainly increasing representatives in clinical trials is part of it. And we have another initiative that's funded by the AHA where we're testing different messaging strategies. If we're recruiting people by email and text message, can we change what the email looks like to make our population that sign up for our trials more representative? And some of that is, what we found actually is that having the message come from someone's primary care provider. So it says, you're receiving this message because Dr. So-and-so thinks you're a good candidate. Is about doubles the proportion of people that participate, especially when we send that message to our black patients. So it's particularly important for people that don't see themselves a lot in clinical research. So sort of a long and winding answer, but I think that it all sort of fits together, and I think that building trust and getting people to participate in these programs is tremendously important.
And then downstream of the clinical trial, when we talked about this application already had feasibility and was already in practice and in use, there I think you're 100% right. It's the people they trust are the doctors that they know, who they've seen in the clinic and they have that connection with. And so our workflow, that's why it was so critical to engage with their patient's vascular surgeon, their primary vascular surgeon who's seen them and who has a relationship with them. And they were the ones who would then, we would talk to them about the application, prep them for that. That way we weren't just cold contacting them, and they had that personal connection and understood the value a little bit better of the application.
All right, I think we'll continue discussions over lunch. Thank you, everybody. This was a wonderful session. Great stuff.